Good afternoon, everyone. Thanks for joining us. We're going to give it a couple minutes to fill the room up. Good afternoon again, everyone. Thanks for joining us. We're going to give it another minute to fill the room up here. Good afternoon, everyone. We'll give it about 30 more seconds to fill the room. Well, good afternoon again, everyone. Thank you once again for joining us for our weekly Wednesday webinar series. Today's webinar is on postpartum hemorrhage in women with inheritable bleeding disorders. My name is Brett Spitale, and I'm the Vice President of Advancement here at the National Hemophilia Foundation. At any point during the webinar, if you'd like to ask a question, please use the Q&A feature at the bottom of your screen. We have NHF staff members monitoring these questions, which we will pose to our presenter after the presentation. This webinar is being recorded and will be available to the community beginning on Friday, May 21st. I'm joined today by Dr. Homa Ahmadzia from the School of Medicine and Health at George Washington University. Thank you for taking the time to join us today. We truly appreciate it. And now I'll turn it over to you, Dr. Ahmadzia, for your presentation.
Thank you so much, Brett, and the National Hemophilia Foundation for inviting me to present this talk. It is such an honor, and this is a topic I care very passionately about. So with that said, let's go ahead and get started. And I'll mention also briefly that my perspective is that of a maternal fetal medicine specialist or someone who had trained in obstetrics. And I've done about a few thousand deliveries or supervised a few thousand deliveries at this point in my career. I have no financial disclosures. However, I cannot begin really without acknowledging the steadfast support and career mentorship as well as sponsorship from Dr. Andy James. She was a mentor of mine at Duke and continues to be one. And she has graciously lent me some of her slides as a foundation for this talk. So before I get jumping into the agenda, maybe at this point, Brett, you could put up the poll. That would be great. I personally, whenever I'm on a Zoom webinar, I like to see sort of who's in the audience, as well as some sort of general survey questions. So I think if we can pull that poll up here and we'll get some responses, I would love to get feedback. You'll see there's some questions that should pop up on your screen about your professional background. What kind of women or patients might you see if you manage clinically or interact with patients with inherited bleeding disorders, and questions about some management related to DDAVP or TXA, tranexamic acid. And whenever you're done with those questions, we'll go ahead and put the tally here. We'll give it a minute or two for folks to respond. And while people are still responding there, I'd like to just go over the overview of the talk. And we're going to be discussing some of the maternal as well as fetal and neonatal risks of bleeding at the time of delivery as a broad background and overview, and then specifically with respect to management with maternal and fetal neonatal risk and consideration. And then briefly, we'll touch on some postpartum considerations and highlights there. So we'll keep going with this case, and whenever if the poll is closed, if you can share those results, that'd be wonderful. I have a case example of a patient who presented in our practice. Oh, perfect. Thank you so much. So it looks like in terms of background, we have a few hematologists and nurse coordinators and a large percent of other participants, which is great. In terms of the inherited bleeding disorder type of patients, mostly people have seen hemophilia A or von Willebrand's disease and some other categories as well. DDAVP seems to really not be in favor. It seems like some people use it at the time of post-delivery or postpartum. However, a lot of folks have not really been using it, or perhaps aren't clinically practicing to be using it. In terms of TXA, it seems like not a lot of folks are responding to use in that area, or they might be using in the setting of time of delivery or postpartum, those who do use it. And it seems like there's a little bit of variation as far as the dose used, either orally at 1.3 grams every 3 hours, or just 1 gram at delivery. So that's kind of interesting to hear the distribution. And we'll touch on that a little bit as we go. So this case study, jumping back to that, and I appreciate the comment there about some of the non-clinical attendees it might not fit. So I, again, will try to be respectful of the diversity here and have presentation for both who might be patients or from industry and not necessarily from the clinical practice. So this was a woman who was 32 years old. She had 3 prior children, and this was her 4th pregnancy. At 13 weeks, she presented with known hemophilia A carrier status. Her father had hemophilia. She had herself reported menorrhagia, heavy cycles, but no specific joint or muscle bleeding. She had some nosebleeds in the past, which used DDAVP for some management every few years, but nothing serious that she needed transfusion or emergency room visits. In terms of her obstetric history, I mentioned she had 3 vaginal deliveries or 3 children. 2 of them were male and 1 were female neonates. They had no complications at delivery. She did have herself maternal bleeding at the 2nd delivery, but most of that was delayed postpartum hemorrhage, and that was in the setting of a retained placenta tissue, as well as an arterial venous malformation or a collection of increased vascularity in the uterus that needed surgical management with a dilation and curettage or DNC and transfusion, as well as uterine artery embolization. So a little bit more of an extensive postpartum course, but likely not directly related to her hemophilia condition. Besides the DNC, she had a wisdom tooth extraction, which she did successfully undergo without major intervention or bleeding. So I wanted to, throughout the case presentation, touch back to this case study, but let me specifically focus on the maternal risks of bleeding at delivery. In terms of the evolutionary changes, pregnant women often have a lot of clotting factors that increase. And if you think about it, that makes sense. At the time of delivery, there's a rapid loss of blood. To help control that rapid loss of blood, the clotting factors increase. And that is primarily why you see several of these clotting factors increase. In terms of hemophilia, you can see factor 8 goes up. Factor 9 tends to not change too much, but then von Willebrand factor does go up as well when we're talking about von Willebrand's disease. And then maternal risk specifically, we talked about von Willebrand factor does increase, and specifically throughout the pregnancy, from 1st to 3rd trimester, it can increase. In hemophilia A characters, the factor 8 levels do not likely increase as much as women without hemophilia A carrier status. And then in patients who have hemophilia B, the factor 9 levels likely do not increase significantly. As I highlighted with the case study, it is important to assess that what are the prior surgical history for the patient. And that will give you a good sense of how did they respond to that challenge, so and forth of bleeding or hemostatic challenge. For our patient, she had her wisdom teeth extracted, and she underwent that successfully. Childbirth itself actually is a hemostatic challenge, and that's important to know that she's undergone 3 successful vaginal deliveries without major immediate bleeding at delivery. In terms of postpartum hemorrhage, I think it's helpful to have an overview of the 3 broad categories of bleeding that we might encounter. At the time of delivery, there's obstetric or uterine bleeding, surgical bleeding, and then systemic bleeding that can also be presented. For obstetric bleeding, we're specifically referring to the bleeding at the level of the uterine arteries and spiral arteries, which is where the placenta is attached to the wall of the uterus. And excessive bleeding or postpartum hemorrhage is where you have abnormal bleeding there. A significant percentage of times that's due to uterine atony, or the muscle of the uterus not contracting fully and caused by vasodilation or excessive bleeding at those levels of those vessels. Surgical bleeding, I would define more here as bleeding with entry into the surgery, such as when doing a cesarean delivery, or at the level of the vessels near that supply the uterus, such as the uterine arteries. And those often can be encountered if someone has undergone labor and the cesarean delivery is more challenging at that point, when the head is into the pelvis and you're having to extend the incision lower, and it creates sometimes increased risk for bleeding surgically. This accounts for about 15 to 20% of postpartum hemorrhage. Systemic bleeding really is when you have that's excessive bleeding beyond just the routine delivery bleeding. And that often is compounded when women have thrombocytopenia, platelet dysfunction. They might have low levels of clotting factor, either for a known inherited bleeding disorder, or they might have anatomical variation or abnormal vasculature, whether the placenta is invading abnormally into the wall of the uterus and that's causing vascular malformations, or hyperfibrinolysis. And in some women who have acute cases of severe bleeding, like abruption, where the placenta is separating, that can cause a hyperfibrinolytic state because the clotting factors are being used. And that can evolve very rapidly into DIC, or disseminated intravascular coagulopathy. And that can certainly compound if someone has an inherited bleeding condition on top of their underlying risk. The incidence of postpartum hemorrhage in the US is approximately 3%. And specifically for primary postpartum hemorrhage, we're defining as within the first 24 hours, having excessive blood loss. And by that, that definition has changed over the years, but most recently in the US has been defined as over 1 liter of blood loss at delivery, whether it's vaginal or C-section. And then 1% of women have what we call secondary or delayed postpartum hemorrhage, that is greater than 24 hours, but up to 6 weeks after delivery. I will note here too, with the more advancement of quantitative blood loss at delivery and that push from national guidelines, these incidences are likely lower than what I think truly we might be reporting, and we're getting better at accurately defining this. So reports of postpartum hemorrhage in women with inherited bleeding disorder, you can see in the literature summary here, compared to the 3% that I mentioned, they're often much higher in women with von Willebrand's disease, hemophilia A or B. And you can see some of the rates of postpartum hemorrhage anywhere from 11 or 9% to about 30 or 40%. So shifting gears to fetal and neonatal risks of bleeding at delivery. In terms of the specific risks, we know that fetuses and neonates who are delivered from moms who have these inherited bleeding disorders are at risk themselves. And specifically, we're talking through the trauma of the birth itself, and specifically vaginal delivery. I want to highlight first for hemophilia in terms of the risks of this being an inherited condition, and X-linked recessive condition is how it's characterized. So you can see how if the mother is a carrier, like in the case study we had here, she herself may or may not be symptomatic. And then if she has a male fetus, that offspring will pretty much be affected or suspected to be affected. And then a female infant may be a carrier as well and may be symptomatic or not. In terms of the genetic status of mothers who have affected males, oftentimes, a majority of times, is really from a positive family history of hemophilia. And so I think that's really important to understand. If there is a family history of a bleeding disorder, that patient should be referred appropriately to hematology and additional multidisciplinary team to really understand what are the risks for the mom, the fetus, and how to best manage that intrapartum and postpartum care. In terms of what available genetic testing do we have, currently that's an evolving field, but I think most traditionally women think of the diagnostic tests such as the chorion villus sampling. We're talking about the biopsy of the placenta or amniocentesis, which on the lower left is a cartoon where we essentially put a needle through the mom's belly to the amniotic sac and take a little bit of the fetal DNA that's floating around and send it for analysis of genetic testing. And then on the real ultrasound picture, you can see the needle that's going through the layers of the maternal abdomen into the black or amniotic fluid there. So those are some diagnostic tests, but however, there's more advanced tests that are less invasive, and that's sort of becoming more commonly used, is cell-free fetal DNA testing, which is based on the scientific premise that fetal fractions of DNA are floating in maternal blood and can be then separated out and analyzed for additional genetic information. And then lastly, I have put on here pre-implantation genetic testing, which may be useful for couples who are trying to screen and identify very carefully if they want to optimize the risk of not transmitting the condition. In terms of the site of bleeding for the infants with hemophilia, most commonly, this becomes an issue when we're dealing with if a male infant in the family have chosen really to have a circumcision procedure, and that's the most common issue that may occur for the neonate. In terms of the other more sort of the morbidity that can result in more serious long-term issues is intracranial bleeding, which if extensive can cause neurologic injury and damage. So with respect to the risk of intracranial hemorrhage and how does that differ by mode of delivery, you can see in vaginal delivery patients, and this is again for moms who have hemophilia and an infant with an affected condition for hemophilia. Those moms who undergo vaginal delivery have a 9-fold increased times risk for intracranial hemorrhage compared to a cesarean delivery. And so that is important. Again, we're talking for the condition specifically with hemophilia. And when you break that subgroup of women who underwent vaginal delivery, the 882 patients, and you break it into spontaneous vaginal delivery versus operative vaginal delivery. And by operative vaginal delivery, what we mean is using assistance from a vacuum, such as the picture there, or forceps. And those are essentially like, we describe them sometimes as spoons that we place on the baby's head to help assist with delivery if for certain indications that mom is experiencing maternal fatigue or there's a non-reassuring heart tracing that we need to expedite delivery. You can see in this same case studies for spontaneous vaginal delivery where the reference risk is 1, for operative delivery that was 4 times increased risk, and for cesarean it was much reduced. And so this really brings home the point that a cesarean, ideally before labor, has the lowest risk, then a vaginal delivery, and then an operative delivery in a vaginal situation. In terms of the risk of intracranial hemorrhage in any fetus and neonate, so we're not talking with respect for women with hemophilia or bleeding disorders, you can see for spontaneous vaginal delivery in a large cohort of patients, if we said that relative risk is 1 for vacuum or forceps, for operative vaginal deliveries, that's about 2 to 3 times increased risk for intracranial hemorrhage. And for cesarean, it's after labor specifically, increased double-fold. And then cesarean before labor really is the lowest risk category if we're trying to minimize the risk of intracranial hemorrhage. So shifting gears to the maternal management of delivery to reduce the risk of maternal bleeding, and with respect to how to approach this, I think this cannot be underscored enough. And I've learned in our institution as well that a team of collaborators, ideally with assistance from a genetic counselor who has someone who has expertise in educating a patient and family about what are their options, adult hematologist when it comes to respect to mother's management and what kind of hemostatic agents we might utilize and how. The obstetrician and/or the maternal fetal medicine specialist will be important for timing of medications. with respect to the timing of delivery and the prenatal diagnostic testing. The neonatologist, certainly the pediatric hematologists, I think are critical when we're dealing with post-delivery follow-up, and then certainly counseling intrapartum. And the nurses, whether they're labor and delivery nurses or nurses at the hemophilia treatment centers. And I think this role cannot be underscored enough, how important the education and awareness and communication is very important. And lastly, but not least, the obstetric anesthesiologist, who is providing analgesia as far as pain control during labor, and then certainly during, if a cesarean is needed, and administering sometimes these products, whether they're factor concentrates, et cetera. Their input and involvement is critical. So with respect to our case study, I mentioned that I've learned this over the years here at GW. She had had 3 prior successful vaginal deliveries, and our plan had been for a spontaneous vaginal delivery. We had considered a pediatric hematology consult prior to delivery, but she had again 2 prior males and a female, so she had been comfortable with overall counseling and had a prior hematologist already lined up for pediatric care. So we had a 3rd trimester discussion with OB anesthesiology, adult hematology, transfusion medicine, and then MFM as well, to plan for delivery considerations. And thankfully, her levels were really in a great range. 123 was her factor VIII level immediately before delivery. In terms of reducing the risk for maternal bleeding, so I want to highlight, as I mentioned, the importance of a maternal factor level and serial monitoring. However, I think it's important to note, even if the levels are great, sometimes they don't correspond always with the clinical phenotype or what can happen for the patient. And in my experience, this is particularly true sometimes with factor 11 deficiency, but other conditions as well. And then using hemostatic agents. And specifically, I wanted to highlight one agent just that I have a little more expertise and work with in terms of clinical and research use. TXA specifically, tranexamic acid. So as far as the obstetric measures that we're talking about, one thing that's really important to underscore is for the obstetrician and the maternal fetal medicine specialist is that we would treat a postpartum hemorrhage very similarly to any woman who does not have an inherent bleeding disorder. So we are always identifying what is the cause, what are additional things we need to consider, and we work through the same algorithm of management of hemorrhage. However, we're more aggressive with potential hemostatic agents as known if the levels are low. And specifically, the thresholds often used are a factor level of about 50 for replacement of those specific factors. And then virally inactivated plasma-derived or recombinant concentrates, rather than cryoprecipitate or plasma, is mostly what's mainstream in terms of usage at this time. I will say and point out that the threshold for treatment, the choice of product, and the dosing, as well as the duration of therapy, are often not well defined from randomized trials because these are rare conditions. And so they're usually from observational studies or expert opinion. So often local centers will define their own practices based on their group of multidisciplinary experts. And then lastly, tranexamic acid is often used as an adjunct. I wanted to take a quick detour here for discussing a little background history. I think that's somewhat enlightening. This is a picture of Dr. Utako Okamoto, who was born in Japan in the early 1900s. And she grew up ultimately to become a physician scientist. And I think for those in the field who are doing research at all, I think you can appreciate nowadays it's challenging for physician scientists who are women, but even that back then it was probably even harder. This picture I liked specifically because, you know, they didn't really have labs and offices and whatnot. So this was a lab they created in their home, and they didn't have additional childcare support services at that time. So there's a picture of her daughter in their home lab. And really, she and her husband, who's also a physician scientist, came up together and created, or rather invented, the tranexamic acid in the 1950s. And interestingly, when it was approved by the FDA for patients with hemophilia who underwent dental procedures, that was the original indication. However, in learning more about the history of the drug, her intention had been, when they first created it, to ultimately help a patient population undergoing delivery. and for it to be used at the time of postpartum hemorrhage. So that is quite interesting and sort of a path and evolution. Her ultimate wish eventually sort of came true, but several decades later, and when the publication of the Women Trial, which many of you are familiar with, this was the large multi-site international randomized trial that showed 1 gram of TXA prevented death from bleeding and by 30% when 1 gram was used. And then I showed here briefly several other ongoing or recently completed randomized trials that have also used 1 gram. And I think it's interesting because doses for prevention or treatment of postpartum hemorrhage in pregnant patients, really, there's no dose finding study, and a lot of these big clinical trials used it with extrapolation from non-pregnant patients. And I think that it has to be cautiously interpreted. So some of the work that we've been doing through my research goals is if looking at dose optimization, and 1 gram in the theory really, or the hypothesis was, if 1 gram can treat PPH, can a lower dose prevent it? And that was what we were hoping to study. And we were trying to look if a lower dose would achieve the targets of the PK and PD, or pharmacokinetic and pharmacodynamic targets. And we gave it intravenously at the time of delivery for women undergoing cesarean birth. And briefly, I want to just go through some of the methods of our study, where we chose these targets from the literature, the PK and PD targets, and we used modified ROTEM, or rotational thermal elastometry, to assess the effects of the TXA on the coagulation parameters. We took blood samples at pre-drug administration and 6 time points after the drug administration, and we measured both PK and PD at both of those time points. We gave the drug, as I mentioned, in vivo to the patient at the time of umbilical cord clamp. So there was no direct concern or exposure for the fetus. And then in vitro, we took blood samples. We added tissue plasminogen activator, or TPA, to cause a lytic situation, and monitored how TXA in vivo would essentially inhibit that and cause stabilization of the fibrolysis process. So we noticed that there was a predictable dose response. We had 3 different doses, 5, 10, and 15 milligrams per kilogram. And the 15 milligram per kilogram group, you can see, is the green one, and the lowest dose was the purple one. And you can see that made sense over 24 hours. Now, this is a logarithmic scale. Most PK studies are. So we zoomed in here on the key 2 hour first, 2 hours after delivery, which is the highest bleeding risk period. And then we made it on the linear scale to show you that all patients achieved above that 10 microgram target for the PK for at least 45 minutes after infusion end. And the average dose for the 5 milligram per kilogram group was about 500 milligrams. In terms of the PD parameter or output, you can see that immediately pre-drug, there was complete lysis with no TXA on board. And then shortly after, it was complete reversal, and all patients, almost all patients, fell below that 17% target for the PD. And then as the drug is clearing out of the body, you can see how the different doses showed different curves, but it seemed to be partially inhibitory even 4 to 6 hours after administration. So when selecting the optimal dose, we had advanced modeling techniques that helped us determine what were the PK and PD targets and what percentage of patients achieve those targets about 30 and 60 minutes after infusion. We chose about 600 milligrams, and you can see the PD after 30 minutes was 90%, and the PK after 30 minutes was 100%, and then 60 minutes as well. You can see that those were generally a reliance of PK over PD helped us choose the 600 target. And then lastly, I wanted to share a slide of how TXA has really become more increasingly used, not only in patients with hemophilia or bleeding disorders, but ever since the Women Trial and the publication of in 2017, and then the consideration of our national guidelines, American College of OBGYN, to include it in management when patients don't respond to drugs to help the uterus contract, it really has taken off. And we're in the process of looking at this updated trends and use. Now, many people ask, well, is there a risk for giving TXA at the time of delivery? And that's a very practical and important question to ask. What I would highlight is just last month, there was published a really impressive systematic review meta-analysis of over 125,000 patients. Some were pregnant, and the women trial was included here. And they showed that the rate of thromboembolic events was not statistically increased in the TXA group versus control group. I think this is the largest study to date that really has taken home the point there that it doesn't appear to increase the risk, even though that theoretical risk is there. So shifting gears to talking about the management at the time of delivery for fetal and neonatal bleeding and how to reduce those risks. In terms of fetuses with known or possible hemophilia, the recommendation, especially if it is a male infant, obviously, is to perform a cesarean delivery prior to labor. I think that is generally pretty agreed upon. However, in some patients, as you can see, our patient had 2 male neonates that did well, and she was a carrier, so that I think there is some controversy, but in general, if it's very strongly suspected to be affected, most patients would undergo a cesarean delivery. We do recommend avoidance or postponing invasive procedures, and I'll discuss what I mean by that. And then in fetuses with known or possible von Willebrand's disease, the cesarean really should be for the usual obstetric indications. And von Willebrand's disease is inherited. However, the pattern for this inheritance is not quite the same as hemophilia. And so it's not sort of traditionally defined as if it's a male fetus, we wouldn't recommend it. And avoiding or postponing invasive procedures is similarly advised because of the risk of the neonate being affected shortly after birth, and also morbidity at the time of intrapartum care or during labor care. And one other consideration is to limit sort of the extended or prolonged pushing or the second stage of labor. And I'll show a figure really why that could be of a concern. Before I elaborate on that point, I wanted to discuss a little bit about the risk of birth injury in general. And if you're talking about probably the lowest category, if someone has a previous cesarean birth and they're undergoing a vaginal birth, they're about 3 times as likely to have increased risk compared to cesarean. But you can see the absolute risk is rather low. It's less than 1%. However, in the breech presentation of a fetus, and most centers in the United States often don't recommend delivery vaginally of a breech presentation. However, some centers with additional expertise, and our center is one, for select candidates, we would offer a trial of vaginal delivery with extended counseling, obviously. And their risk is much higher for intrapartum birth for the neonate with vaginal delivery compared to cesarean. For patients with hemophilia, that risk is much higher at 9-fold increased risk for cesarean compared to vaginal birth. For vaginal birth compared to cesarean. And so with respect to relative risk, you can see that this is something for women who have hemophilia that we take very seriously and trying to educate about what is the absolute risk and the relative risk. So when it comes to the birthing process and evolutionarily, why is it more risky really for women to undergo childbirth? And you can see from the historical perspective that chimpanzee, the head diameter is much smaller and more appropriately, not really as much risk coming through the birth canal compared to evolutionary moving on to the human birth pelvic anatomy and the limited space essentially and risk for intracranial injury. And from this Williams obstetrics book, you can see how much molding or overlapping of the sutures and kind of shape a process that has to occur for the fetus to pass through the birth canal. And so that risk for intracranial hemorrhage is certainly higher when you're undergoing vaginal birth compared to cesarean delivery, which does not go through the same process. It's also interesting, I think, to think about this from just asymptomatically neonates who have intracranial hemorrhage and undergo spontaneous vaginal delivery, that up to a quarter of them by MRI. So if you did imaging on 88 or so healthy newborns and you saw spontaneous vaginal delivery group, about a quarter of them would have intracranial hemorrhage by MRI. They would not have symptoms of any issues, but that would be found on their diagnosis. For assisted vaginal delivery, similarly, that would be about a quarter to a third, even a little higher. Now, cesarean delivery, that was much lower. So you can see how even without an inherited bleeding disorder condition, that you can have intracranial hemorrhage, and that can be a normal process that babies can recover from. Now, however, I think if in patients who have hemophilia or other bleeding disorders, this is much a more higher risk or concern situation. So by mode of delivery, in this other study, you can see that for planned vaginal delivery, women who underwent a spontaneous delivery had much lower risk of 1.5% risk of intracranial hemorrhage. However, compared to assisted vaginal delivery, which again was vacuum and forceps, that was 10%, so much, much higher risk. And an interesting note here is that of those women who had the assisted vaginal delivery, 18 of those women actually underwent that procedure with a known family history. And so that was something the providers may have known about and still underwent that delivery process. And compared to the cesarean before labor, that risk is much lower, 1.6%. And so that's really what we're discussing, is the risk of morbidity and increased risk when undergoing an assisted vaginal delivery is the highest, then followed by a routine vaginal delivery, and then a cesarean delivery before labor is the lowest risk. So one of the take homes, particularly for patients with hemophilia, known or suspected fetus that is affected, is to avoid operative vaginal delivery in particular. And in general, for women with inherited bleeding disorders, to be really cautious and avoid this, because that can increase the risk of complications, not only for the mother, but the fetus especially. The other invasive procedures that I referred to avoiding were things like fetal scalp electrode, which sometimes we use to monitor the heart rate if there's concern from external monitoring. And this is a tiny little clip or electrode, but usually does not cause any harm or issues for the fetus. But if neonates are affected, this could produce a large hematoma and complications at the surface of the skin. And this is just a picture of the cord blood, the tube that we actually collected in, but a reminder to say that you, rather than getting blood sample from the neonate, can get it from the cord blood at the delivery. And so why it's so important to coordinate with the obstetric provider, the lab medicine team, the transfusion team, and everyone to make sure that the appropriate test is sent out and in a timely way. And in our case, I will go back to this case example. We can show that the patient had received her epidural without any products or complication. Or factor levels were again over 100%. She had normal vaginal delivery without any assistance. Her blood loss or estimated blood loss at delivery was 400 milliliters, which is normal. We had collected the newborn cord blood, however, it did clot off prior to being analyzed. And so that is something to optimize how quickly it's collected and then carried over to the lab, or sent via courier to a lab that can analyze it appropriately. And then we had a short interval follow-up with OB and MFM to specifically monitor risk of perineal hematoma or excessive vaginal bleeding postpartum, which often the obstetric provider can give a little more guidance about what's normal, not normal. So the newborn blood that was collected, I mentioned that as well, was cut off. We said that, sorry. And then the factor VIII levels, interestingly, 2 months after delivery for the mom were about 47%. So they did drop back to her baseline. And then she had planned to follow up with pediatric hematology, as we had advised. So to summarize some of the delivery recommendations, and an affected male fetus or possibly affected male fetus, and specifically referring to the hemophilia here, especially if the factor levels for the mom or above the the 50th percent in the third trimester. We would recommend hemostasis center and the multidisciplinary team approach. And a female fetus or unaffected male fetus, I think routine care is appropriate. Now, when the factor levels certainly drop at a more concerning level, that should be managed more aggressively, even if the status of the fetus is not affected or it's female. So postpartum management, I'll mention a few takeaways from that as well. In terms of things to avoid postpartum bleeding, it would be optimal to have the factor levels above 50% and replace if they're below 50%, certainly if they're clinically having issues with bleeding. Avoiding the non-steroidal anti-inflammatories or NSAIDs, specifically because they affect platelet function and can aggravate bleeding and complications from bleeding. Tranexamic acid, using it as an adjunct, and that can be decided upon in conjunction with the OB and the MFM and hematologist, and certainly assessing how much bleeding is occurring. DDAVP after delivery for factor VIII deficient women is something to consider. And often if patients have responded to this in the past, that often encourages the use, usually in the postpartum period. And then short interval follow-up, as I mentioned, with the OB or MFM team to assess the clinical bleeding, and not the standard. We usually have 6-week follow-up or 4 to 6 week follow-up, but really these women should get a closer follow-up beyond routine care. And then I wanted to highlight here some data from Dr. James and her group, where they looked at the factor VIII levels in unaffected women. And you can see the dip really is about that 10 to 20 days postpartum when normal factors drop. And that's really the time where women might be fine and then have a delayed postpartum hemorrhage. And so that's important to advise, counsel patients about this window of risk or time period. So in summary, I would like to say that women with inherited bleeding disorders, maternal risks of bleeding at delivery are likely related to factor levels. And so monitoring those in a multidisciplinary team or fashion is very important in preparing for delivery. The fetuses and neonates are at risk for bleeding at the time of delivery, especially for hemophilia patients. And a multidisciplinary team approach is the best way to appropriately prepare for this and counsel the patient. Reducing the risk of maternal bleeding requires the assessment of the factor levels, as we talked about, and possible use of hemostatic agents, things like tranexamic acid or DDAVP. Reducing the risk of fetal and neonatal bleeding requires the avoidance of invasive procedures, such as the scalp electrode or forceps or vacuum, especially in fetuses that are male and with family history of hemophilia. However, in general, for women with inherited bleeding disorders, this is something we want to minimize. And then the lowest risk category for avoidance of this is a cesarean prior to labor. Postpartum management, just to highlight, is advised to avoid NSAIDs and use hemostatic agents as adjuncts when needed. And then lastly, I just wanted to thank and acknowledge the team of my mentors and collaborators on my K grant work that I highlight some slides. It really would not have been possible without them, and Dr. James obviously is included. So we can stop there, and I'd be happy to take any questions.
Thanks so much. We appreciate it. We do have several questions that came in, and I'll start from the top here. How well is postpartum hemorrhaging tracked?
I'm sorry, could you repeat that question? How well is it tracked? Or
correct? Yes. Yeah.
Okay. So the measurement, that is something that unfortunately in the field of obstetrics, I think has been a challenge. In terms of what's gotten better about it, I think is there has been a push about quantifying blood loss and more about weighing, for example, sponges after delivery and being very mindful of trying to subtract out amniotic fluid, for example. And at our institution, what we do for quantified blood loss is we have a drape, for example, for women undergoing vaginal delivery for the immediate delivery that has amniotic fluid. And then after the baby, we have another drape for the bleeding, and we monitor and count that. So we have two different drapes. And then we weigh everything at the end and subtract out how much the drapes weigh, obviously. So the nurses and the doctor team all do that together. And so quantified blood loss has really been the mainstay. I think there's room for improvement, certainly. And I think clinically, we always tend to underestimate this because it's somewhat subjective. But I think quantifying blood loss has definitely become, it's gotten better, but I think we can, there's room for improvement. I think technology and industry will hopefully help with that.
Great. Thank you, Dr. Ahmadzia. Next question comes in. When you are planning for delivery, how do you balance patient wishes and medical recommendations?
Yeah, that's a great question. I think that sort of comes with the art of medicine and practicing longer. I think I've definitely noticed that there are guidelines and there's recommendations, and then there's listening to patients and really working with them to try to make sure they have an informed understanding. What are their risks? And then what are they ultimately comfortable with? And that is a little bit of give and take. And I think for each patient situation is unique. And the term we often use is the shared decision-making model. And I think that has, I would say, in, I don't know, the last maybe 20 to 40 years probably has become more mainstay. Probably wasn't quite that way a couple of decades ago.
Great. Thank you. Next question that comes in. Are you concerned with the amount of fluids given to women during labor and delivery and the use of DDAVP? How do you handle that to avoid hyponatremia?
Yeah, no, thank you. I think that is one of those risks and concerns that often intrapartum, we are mindful if we ever use that, and sometimes restricting free water, although patients aren't really drinking a ton of water intrapartum. But I would say minimal use of fluids is advised. And I think being mindful of selecting DDAVP use for patients really who are known responders, and if we think that somehow is better, and then the other factor concentrates, which often again is a joint discussion with the hematologist and the OB or MFM to really assess what's the best medication for that patient. But that the question certainly highlights an important risk that we want to be mindful of, and quantifying sort of how much intrapartum fluids they get, whether it's intravenous or through just oral intake, is going to be important.
Great. Thanks, Dr. Ahmadzia. Next question is, what are the current barriers, or some of the current barriers, to prenatal diagnosis?
Yeah, I think prenatal diagnosis, one of the challenges, I will say, one of the challenges in general is trying to get these women who might have a family history to be seen pre-conception, to really give them all the information about, what are the risks involved for them, then the future child. Ideally, before they're in a situation, they have to make rapid decisions, or outside of a window, they can make some of the time decisions for testing. So I think some of that pre-pregnancy planning is a challenge, but then technologically speaking, I think we're still, the companies who are making and producing these tools like non-invasive prenatal testing are refining and kind of optimizing how we can make them targeted for patients. And I'll give you one example where probably 5 years ago, we were just testing, for example, the three main chromosomes, trisomy 21, 18, and 13, and gender were the four, I guess, big categories. But now it's pretty routine, where we send it sometimes for patients who have a suspected anomaly, a big genome array. So a really much wider array. And so now I would say targeting, the challenge for prenatal diagnosis is getting targeted tests more widely available, to really allow clinicians to have targeted use of them for clinical situations would be another barrier or challenge.
Great, thank you. Next question that comes in. Did you do a head-to-head study on using factor prophylaxis versus TXA? If so, what was the outcome?
Yeah, that's really an interesting question. Thank you. So we did not, in our dose optimization study, look at factor replacement. This was strictly for TXA dose assessment, and we had the three groups I mentioned: the low, medium, and higher dose. I think factor assessment, and again, those were patients who didn't have inherited bleeding disorders, but I think factor replacement versus TXA, that's a very, very valid, important question. And I think these kind of studies only really can be done if we have a consortium or a collection of sites that are willing and interested to participate, because one center is not going to have the volume to really produce meaningful outcome data. And so we're going to have to be more organized in thinking collectively how to establish these larger networks of trials and uniformly being consistent with the diagnosis of how we choose and then manage. So I think there's some challenges there, but it's a really great question. I think one day, hopefully we can answer it.
Great. Thanks, Dr. Ahmadzia. The next is a two-part question. Great questions coming in here. Are there any adverse effects to consider when using TXA? And does TXA influence a woman's ability to breastfeed?
Yeah, they are great questions. So adverse effects, I probably put up there the most important one, I think, as far as there's a theoretical risk of increased clot, but that systematic meta-analysis of over 125,000 patients did not show increased clot risk, pregnant and non-pregnant patients. And again, those patients have other comorbidities who are undergoing cardiac surgery, orthopedic surgery, liver transplant surgery. They're going other kinds of surgical procedures who get TXA. And so they're not just routine healthy patients either. So I think that's the biggest concern. From other side effect profiles, I think nausea or vomiting or diarrhea or some GI side effects are been shown in studies to be there above placebo. But I think the consideration or trade-off you have to remember is what is the potential benefit and the risk. And then lastly, I'll mention a little bit the risk about seizures that has been shown in some cardiac surgery patients when the dose often is much higher than the doses that we're talking about, like 1 gram. They're often much, much higher for cardiac surgery in the literature that produce that risk of seizures. I think those are kind of the things. And then the second part was about breastfeeding. So there's no data or literature I'm aware of that affects breastfeeding abilities and production of milk or lactation success. I can tell you as far as levels of breast milk exposure in our cohort of 30 patients, we did measure about 7 out of 30 had breast milk samples. And it was consistent with the 1 or 2 other publications in the literature that showed about 1% of maternal concentration gets in breast milk. So a fraction of it basically gets in breast milk, and it has such a short half-life of about 2 hours that it's very short-lived. And so as far as the fetal risk, I don't think it's, especially if you're given a cord clamp, is not high at all in my mind.
Great, thank you. The next question that comes in says, what is your treatment recommendations to enable women to have neuraxial anesthesia, or should this be avoided?
Yeah, I think that's a good question, and certainly pain control, whether we're talking about for vaginal delivery or if they need a C-section, and neuraxial regional anesthesia versus general anesthesia is much preferred, because general anesthesia also relaxes the uterine muscle and increases hemorrhage risk, and that's known. So I think that's really important. Now, with full disclaimer, I'm not an obstetric anesthesiologist. Dr. Berger here is one of my colleagues who is, and so they kind of have the final say on who gets it, because they're putting the needle in the patient's back and ultimately decide. And so I think in my experiences, it's usually an assessment of factor levels and as well as their bleeding history or surgical challenge in their history and how they've done. Sometimes they will want additional factor supplements pre-epidural placement. I've had patients sometimes with factor 11 deficiency who had low factor levels, they request that, but sometimes they're fine without it. And so it's really a joint decision with them involved.
Great. Thank you. The next question that comes in is, do premature or late births have any effect on PPH?
So preterm births, I think if I understood that correctly, is preterm births and effect on hemorrhage. So usually preterm births occur, whether if they're spontaneous, sometimes they can occur in the setting of a known, like unknown reason, and abruption, for example, might be one. That could be one case where certainly if the placenta is separating off the wall and causing the mom to go into labor or have the water break, that bleeding risk is much higher. And that's a very well-established or known risk factor for PPH. However, if it's a early preterm birth, because there might be just spontaneous labor and there's no infection and mom delivers, not necessarily. If they have a vaginal delivery. Now, in a C-section in a very preterm baby, sometimes we'll have to, like a 24 to 26 week delivery, sometimes we'll have to do what's called a classical uterine incision, where we go up and down on the uterus instead of side to side on the uterus. And again, we're not talking outside on the belly, on the inside. And that can certainly increase bleeding risk for mom and postpartum hemorrhage risk, but that's a very specific window or time we're talking about.
Great, thank you. The next question that comes in is, how can HTCs work closely with rural hospitals when a carrier goes into the birth plan and delivery? Who should be included in consultants?
That's a really, really good question. I think that highlights some of the challenges in our healthcare infrastructure and health systems management. I think having sort of networks and support systems for these rural hospitals established and known, and early screening or early identification, I think that's critical, right? It's way better to know right before or right when the patient hits the hospital or is in prenatal care, ideally, that this patient could have an inherent bleeding disorder, to prepare adequately ahead of time and to have an identified core team of people that they can rely on. Nowadays with Zoom, remote consultations are more easily done. And so I think that is a potential for future quality improvement measure. But I think the identification part really needs to happen with the obstetric team and the patients to advocate for that. And if and those two entities, if they don't sort of sound the initial alarm that they need the team, it's really hard to mobilize when the patient's having a hemorrhage and have a good outcome.
Great. Great. There's still some more questions if you're okay, Dr. Ahmadzia, continuing here. Great. Thank you. When should a woman with a bleeding disorder contact her hematologist post-delivery rather than her OBGYN?
Great question too. I think every OBGYN might have a slightly different comfort level with managing patients with inherited bleeding disorders. As I mentioned, Dr. James at Duke, really that was her niche, and I've adopted and developed that niche as well. And I would be comfortable prescribing TXA or, comfortable talking about the risks, but not every obstetrician might. And so I think I would typically recommend probably starting with the hematologist. But sometimes questions when it comes to like breastfeeding, or if the amount of bleeding is normal or not, I think those would be better for the obstetrician. And then assessing just what their comfort level is. So prenatally really having those conversations, that's also good.
It's an interesting question that comes in. What about women choosing to have home births? Are there resources for doulas and midwives?
So I would take this means in the setting of inherited bleeding disorders, probably.
Correct. Yes.
I think this. I think home births for certain patient populations, who are well resourced and supported by hospital infrastructure, could be appropriate. But I get a little nervous, to be honest, when it comes to home birth. And the reason is because hemorrhage can happen so quickly. And I mean, the amount of blood supply going to the uterus at a full term state, it's about 500 milliliters per minute. So if you think about how much volume that is and how fast that can be, and how quickly bleeding can turn from okay, and then really not okay, even delays for transfer or recognition. And that just makes me really worried about ultimately good care. And so I personally wouldn't, for women with an inherited bleeding disorder, advise that. So that's at least my 2 cents.
Great. Another question. I know we're coming against the hour here, but we still have some great questions coming in here. So it's often difficult for women to gauge what is normal versus abnormal bleeding during menstruation. How can they be supported to accurately self-assess whether their amount of bleeding during the postpartum period is normal?
Yeah, that's a really good question too. We don't have, I would say, quantified standards that I can tell you objectively, this is the volume that's appropriate. I can give us, over the years and clinical experience, I usually get a sense, how many pads are you soaking and how often and how big are the clots? And, so I have a sense as an obstetrician, you have a sense of knowing what's normal because sometimes patients say, I'm passing all these clots, but they're like pebble size. So that's okay. But I think for patients, I can't really refer to a known chart or strategy, but I think talking to the obstetrician and whenever you're not sure, I think that's the key takeaway is that if you're not sure, you should ask someone, your healthcare provider really, and your obstetrician should be that first line of, is this normal? If you're not getting the answer that you're comfortable with, I think it's okay to ask or push for things like, can I get a blood count check? Can I get an assessment of my hemoglobin or if I'm really anemic or not? Or sometimes an ultrasound can help evaluate this. And that's okay. I don't think that's wrong to advocate or ask for those things. And all medical doctors, can learn from experiences. And so that's, no one's perfect. And I think so advocating there's nothing wrong with that.
And one last question that's come in, Dr. Ahmadzia, is you mentioned to use TXA as an adjuvant when needed. What do you recommend as a prophylactic dose to prevent PPH and for how long?
Yeah, that's a great question. I think I would usually make that decision on a patient by patient basis right now with my hematologist and use the patient's clinical history, their experiences and kind of delivering circumstances to help inform that decision. If the patient had a normal blood loss at delivery, has really low risk, for bleeding history and her factors are great, levels are great, I might not prophylactically necessarily give her a drug. Maybe she won't need it, but you can start it, if her bleeding is excessive. So you might want to give her the prescription and how much. Usually I've often, in working with the hematology team, sometimes I've heard them use about 1 gram every 8 hours or twice a day. I think those are reasonable doses. And they tend to work pretty fast. It's not like it'll take a day or two. Usually it'll work pretty fast. And so I think it's a little bit case by case and having a patient have a prescription never hurts.
Great. Well, I'd just like to take the time to say thank you, Dr. Ahmadzia, for joining us today. And thank you for lending your expertise to our audience. We appreciate your time. And I'd also like to thank each and every one of you for joining us as well, too. Please note that this recorded webinar will be available on Friday, May 21st at hemophilia.org under the events tab with all of our other archive webinars. Also available in the events tab is our upcoming schedule for our weekly Wednesday webinar series. Dr. Ahmadzia, thank you once again for joining us. We really appreciate it.
Thank you so much for having me. It was such a pleasure and an honor to be here.
Yeah, great presentation. Thank you.
Great. Have a wonderful afternoon, everyone.